First you ask me what it feels like to be a freak.
Nathan, call 911.
Hey, do you love me? I'm untouchable darkness.
Hey everybody, my name is Kevin Mackey. I'm the Medical Director for Sacramento Fire Department. Today's topic is around Policy 50/50 for the Sacramento County EMS Agency. This is our triage to waiting room policy that we're going to cover today. There's been a lot of changes. It's actually in version 0.18 right now, and there's been a lot of discussion, both at the hospital side and on the pre-hospital side, about exactly what this policy looks like and what it's meant to do. So this video will hopefully walk you through the nuances of the policy, and so we have clarity, clear message, and consistency as we apply this policy for the patients that we take care of. So let's get going. All right, so a while ago, Sacramento County developed a policy 50/50, which was originally a destination policy, but there's a piece that's been added onto it because we're dealing with some pretty heavy wall times, as you know. And this add-on for direct to waiting room was an attempt to begin to decrease the effects of wall time. So for clinically stable patients, we could transition those patients to the waiting room so that we can release those vehicles back to the street. Because as you know, when we transport a patient to a hospital, our next obligation is actually to the patient that's about to call 911 that we need to respond on. And so trying to implement this policy in a sensible fashion will help us produce more vehicles that are available to respond to 911 calls. So the intent is to have EMS personnel place a low acuity patient in the waiting room. That's the intent of this. And it's specifically designed for a subset of patients that we are going to walk through. Okay, so let's go ahead and start to break this whole thing down. So let's start with the process en route to the hospital. So when you are en route to the hospital and you already know that you have a patient that potentially meets waiting room criteria, it's very important that you take the time in your radio report to notify the RN that the patient is waiting room appropriate. What this does for the RN on that side is they get to pre-plan this a little bit, and they can begin to think about what you've told them, and then they can also look around at the beds that are available, and when you arrive, you can make a decision about where this patient goes. This helps the RN do the pre-planning process. So now you've arrived at the hospital. The initial steps always are to check in with the intake RN. So check in with a nurse who is the intake nurse and notify that nurse that, hey, this is the patient I talked to you about a few minutes ago or that we called in about that is waiting room appropriate and meets the 50/50 policy. If at that point you are directed to go to the waiting room, go ahead and transfer the patient to the waiting room. Check in with the triage RN. Don't just drop the patient in the waiting room, right? You need to check in and let the triage nurse know that the patient is there, and then document that the patient was placed in the waiting room. If possible, obtain all the appropriate signatures like you would. But remember in the policy, this doesn't actually require a signature. We want you to get a signature if you can. But if you're having a moment when there's a refusal to sign, that's okay. This is covered under the policy. However, if you've arrived and you are directed to wall time, then that starts a very specific scripted process that I want to go through with you right now. So if a patient meets the 50/50 policy, you're at a point where you can go two directions. There are two ways that this whole thing goes down. Okay, so this screen shows two sides of the coin, right? The haves and the have-nots. On the left side is the haves. The patient must have a GCS of 15 or be at baseline with a caregiver in attendance. In addition, the patient must exhibit decision-making capacity or, as I said before, have a caregiver in attendance. That patient must be able to stand, or maintain a sitting position. And then there's a list of vital sign criteria, which I won't go through, but basically, essentially, what we would call stable vital signs, okay? Now let's go through the have-nots. On the right side, the have-nots, they can't have any activation criteria. They can't be in a collar or on a board, but if those things are removed by the staff, then that eliminates that side of things. I'm talking staff at the hospital. If they have no focal weakness, dizziness, or vertigo that is now resolved or needed a 15 to 30 minute vital, and we are going to get into this in just a second. They cannot be postictal. Again, we're going to get into that in a second. They cannot have any active chest pain. We are going to get into that in a second as well, because those 3 bullet points have led to a lot of conversation. They can't have a history of syncope, and if they're a child, they can't have a history of a brief, resolved, unexplained event or a bruit. They can't have been given naloxone at any time prior to EMS care. This includes with law enforcement. And they can't have received any narcotic analgesics. So they're the have-nots, all right? That's the list they cannot have. All right, so what do? We are now in wall time. First thing, take out the fire EMS waiting room form that you all have and begin to fill it out. This has been provided for you as a tool from the EMS division for a couple reasons. One, to communicate to the hospitals what has happened while we are on the wall, because you will be leaving this with them. The second thing is to also document clearly what had happened while you're on the wall in a second place, which is on this form. And the third thing is really to help us help you if questions get asked. So we want to make sure we have clear and accurate documentation of exactly what happened. All right, so you see the form over here, begin to fill it out. All right, in conjunction with this, also notify your charge nurse or the intake nurse that you have a 50-50 policy patient. But refer back to what I said earlier. You've already done that. You've had the conversation as you came in, and the triage nurse or the intake nurse knows that this patient meets 50-50 criteria, but for some reason or another, you've ended up on the wall. But a clock has definitely started. All right. Next thing. Nicely wait 20 minutes. Please wait 20 minutes. Get a set of vitals of 15 minutes into this, okay? And then this is all about communication as well, right? We're going to begin the process of moving this patient to the waiting room. At around 18 minutes or so, let the nurse know that, hey, you know what, it's been 20 minutes, my patient has stable vitals, and I'm going to the waiting room. At that point, go to the waiting room, okay? The biggest concern about any of this that we have heard at the EMS division and the EMS captains have heard about is the fact that our personnel are concerned that there may be repercussions, that they're not doing something proper, or that there may be actions taken. This policy, remember, comes from the EMS agency. This policy actually empowers you to do this. And remember again that although this patient is on hospital property, for whatever reason, the hospitals are not able to or have elected not to take over responsibility of this patient by taking handover of care. That patient remains in our care, and we are making the decisions for that patient in that circumstance. All right? This is not emotional. It's not meant to be punitive on the hospitals. We are making decisions because, again, as I said before, our responsibility now lies with the patient that is now calling 911. We have done our duty for the patient on our gurney, and it is time for us to move on. So, continuing, move that patient to the waiting room. At that point, I want you to attempt to get a staff signature. Take a picture of the EMS waiting room form and attach that to your PCR. Leave that filled out form with the triage nurse. It has all the vitals there, it has all the patient information there, okay? And then very important, please, please do this. Add hospital waiting room in the event log under treatment. Why is that so important, right? So we generate like over 98,000 pre-hospital care report forms. And it helps the EMS division be able to quickly search for these forms if things are documented appropriately. That's why you're getting a lot of stuff through the MCD this month about documentation. It's really helping us and it's helping you as well. Help us, help you. Okay. All right, so let's go to option 2 now. So option 1 was we've arrived, we've had our 20 minutes of wall time because for whatever reason the patient wasn't moved directly to the waiting room. Now we're to that patient that arrived that couldn't go to the waiting room right away. All right, this is a cycle. It's a 30-minute consecutive cycle, okay? All right, so the letter of the law says after 30 minutes, if 2 consecutive 15-minute vital sign assessments were done and the patient now meets the criteria outlined in section A above, which is the haves, right, in both assessment cycles. Remember the haves, the have-nots? These are the haves, right? So if they have all of these criteria, the patient can be moved to the waiting room after that 30 minutes and 2 consecutive 15-minute sets of vitals. So let's break this down again. I'm going to go through this one more time to really emphasize the key salient points. I hope by now everyone's kind of got it, but let's just go through this again. All right, here's our list again of the haves and the have-nots. Okay, look at this list, memorize it. If you need to, take a picture of it, print it, keep it with you, put it on your phone, whatever it takes, so you know the haves and the have-nots, okay? On the left are the haves. They have to have this GCS of 15 be at baseline. They have to exhibit decision-making capacity or have a caregiver, and they have to have clinically stable vitals, have to be able to stand or sit, okay? Bottom line. Have-nots, you can see them on the other side. We're going to talk about the controversial ones or the ones that have created more discussion. The key to the waiting room for option number 2 is to begin your 2 consecutive 15-minute vital sign assessments over 30 minutes and begin to timestamp, okay? Take the form out and begin to fill it out. Do yourself a favor, right? Begin to fill this form out when you know that you're going to be on wall time and you know that this patient is likely going to be able to go to the waiting room. You don't have to fill this form out if it's obvious they're not going to go to the waiting room. If you have an elderly female with a hip fracture and they can't sit or stand, right? If you have someone who's, had a stroke or altered level or syncope or brewery, like, you don't have to fill this form out for them. These are for the patients that you know are probably going to be ending up in the waiting room. So when you get to that point, the form is already filled out. All right. If the patient meets the waiting room criteria after 2 sets of stable vitals, as we've outlined above and as in section A of the policy that you've already taken a picture of or you already have with you, right? Finish filling out the form and continue the procedure, moving the patient to the waiting room. It is advisable to constantly, collegially, and respectfully communicate your intentions with the intake nurse. But I want to emphasize again, this is not a decision point on the hospital side, okay? You have the backing of not only me, but also the EMS division, the leadership of the fire department, and the county EMS agency to do this, because we are trying to address wall times and get units off the wall and back into service. So let's clean up some of this confusion, all right? Here are some confusing points. You can see these arrows pointing to it. Has focal weakness, dizziness, vertigo, or recent seizure activity. The question is, what is recent? And then has active chest pain. What does all of that mean? All right, so let's clear this up. If the following have resolved, has focal weakness, dizziness, vertigo, or recent seizure activity. So what does recent mean? So if they have resolved focal weakness, they fall under this. If their dizziness or vertigo is resolved, which I can't imagine it's going to happen very often, but if it does, waiting room after 30 minutes, 2 consecutive vitals are stable. What's this recent seizure activity? What defines recent, right? Is it yesterday, 2 days ago, 3 days ago, an hour ago? Here's the tool. Objective evidence that this patient recently had a seizure. What does that mean? That means you can find evidence of they bit their tongue, they were incontinent of stool or urine, or were postictal in your presence. that is enough evidence of recent seizure activity that they cannot go to the waiting room. Okay? If they had a seizure yesterday, or someone tells you they had a seizure 3 hours ago, but they're alert, oriented, postictal, haven't bit their tongue, aren't incontinent, that person is not recent. They can go to the waiting room. Okay? What about active chest pain of suspected cardiac origin? So what happens if I'm treating under this protocol, they had active chest pain, I gave them nitroglycerin, and their chest pain went away, and they haven't had chest pain since we arrived, or even after we arrived, and we've had 30 minutes now of no chest pain, and we're not currently treating it, because remember, we don't do any more treatments on the wall either. We're not treating it. They don't have any active chest pain. They have stable vitals. That is not active chest pain. That patient can go to the waiting room after 30 minutes, 2 consecutive stable vital signs, okay? So no active chest pain, seizures. I hope that discussion helps clear it up for you. I know it's going to create questions. You know me, I'm pretty easy to find. Send me your questions. All right. So putting it all together for option number 2, fill out the form, start early, right? Get the 2 consecutive sets of 15-minute vitals. Nicely wait the 30 minutes, please, all right? Be in communication with a nurse, right? This is just out of courtesy and out of respect. We work together, we're on the same team. We are not trying to create adversarial relationships, we're trying to communicate. Obtain your 2 sets of stable vitals. Nicely at that point, tell the nurse that you're been 30 minutes, you have these 2 sets of vitals, and you are moving to the waiting room, right? Again, this is not a discussion, okay? This is an information. We are moving to the waiting room. Remove the IV, go to the waiting room, and just as before, try to obtain the signature, take a picture of the form, put it in your PCR, leave the form that you filled out with the nurse, all right, and then please do the appropriate documentation of adding hospital waiting room in the event log under treatment. Okay, I know this is a lot. I went to the lengths, and I want to acknowledge and thank actually publicly Firefighter Hines. He developed this PowerPoint for me and with me. And so I have him a lot to thank, and the rest of the EMS division for getting this out to you guys. Okay. So reminder, you need two sets of stable vital signs over 30 minutes. I've said that 100 times now. That should be pretty much cemented in there. And then again, a reminder about the decision-making authority. This is not an emotional decision. This is not an adversarial decision. This is a decision based upon the fact that we have the public that we serve, and we have others that we need to serve that are calling 911, and we need to get back in service. So we will respectfully move these patients to the waiting room if they meet the criteria and are appropriate. And we have the backing of the EMS division, the leadership of the fire department, the EMS division, and yours truly as well. All right, we are almost there. Hang in there. A couple things have been added to the form we just want to point out to you. Very key things. One, an EMT or a paramedic can fill this form out. It doesn't need to just be a paramedic. So this can be filled out by an EMT as well. And EMTs who are watching this, pay attention to this form, look at it, get familiar with it, know where it is, know how to fill it out, and know who to leave it with, okay? And secondly, on the back side of this, there's a QR form because we know despite our best efforts, there's still going to be some questions asked, there's going to be some hurt feelings, there's going to be some emotions, all right? And so keep the emotions out of it. Just be very respectful and matter of fact, and if someone at the hospital has trouble with this, show them the back of the form, tell them they can click on that QR code, and they can communicate directly with the EMS agency themselves and express their concerns. Okay, and the EMS agency will take care of it, and they will feed it through the appropriate channels as needed. All right, here's a quick screenshot of the event log documentation. You can see event log, hospital waiting room is right there under treatment. please do us a gigantic favor and make sure you're documenting that every time you take a patient in the waiting room that you've either had to wait for any period of time. The ones, remember, that go directly to the waiting room when you arrive, they don't need this form and they don't need this clicked. Okay, these are only the ones that we had to wait for a process to get them to the waiting room. All right, a few do nots. These are big ones. Do not, under any circumstances, no matter what, walk your patient or gurney your patient or wheel your patient through any door in the entire hospital other than the ambulance bay door, okay? It's extremely critical. Don't take them directly to triage, okay, because that really messes up the whole process and takes out our ability to defend your actions. So do not take them from the lobby to a lobby, from the street or anything. Ambi doors only. All right. Go straight to the do not go straight to the waiting room on arrival unless there's a mutual agreement to. Okay? Have that discussion. If the triage nurse, and you've already warned them, hey, I've got a waiting room appropriate patient, remember you did that in your radio report. I've got a waiting room appropriate patient, you show up and they say, yep, thumbs up, good, all right, go. However, if they direct you to the wall, then that starts your 20-minute, okay? So lastly, if everything's fallen apart and you just have tried everything you can and nothing is working, after an hour of waiting, or if you're having ongoing troubles, EMS 22 and EMS 23 are absolutely there to support you 24/7, 365, okay? They know this drill, they've been involved in this, they have your back, and so you have help out there. You don't have to fight this fight yourself. All right. Well, that brings us to the end. There is going to be a short quiz attached to this as well so that we can get you some CE for this. This will be 1 hour of CE. Okay, and on behalf of the EMS division, we just want to thank you for the ongoing incredibly challenging and difficult job that you're faced with, especially when it comes to having to wait in a hospital to drop off your patients. We know that this isn't ideal for our hospitals, it's not ideal for you, and it's most definitely not ideal for our patients. And so let's keep working through this together. Let's keep actively engaging in dialogue, discussing ideas, making suggestions, but for the time being, this policy is to empower you to help the next person that is calling 911 and to enable you to get back to the streets, okay? Thank you so much for your time. Thanks for watching. Reach out to me with any questions. Till next time, Doc Mackey signing off.